rotate towards, provide a little bit of flexion. Where do you feel a stretch?
I'm sure I'm supposed to feel it right here.
Here? Okay. So I'd perform this bilaterally. So I would depress the shoulder, side bend away, rotate towards, and then flex the cervical spine. Again, that is stretching the upper trapezius. So I'd compare visually how it looks, but I'm also going to use my measuring tape. Alright, so here's my measuring tape. So I'm going to measure the chin to the acromion. So I'm going to depress the shoulder, side bend away, rotate towards, and elevate. Then I would sacrifice my stabilization and use my tack to help hold it against the patient's chin, and I would measure from the chin to the acromion, which is 17 centimeters. Move to the opposite side, depress the shoulder, side bend away, rotate towards, and flex the neck, cervical spine. Sacrifice stabilization. Ask my tech to help again. You could hold that up against the chin. Then go to the acromion. This is 16 centimeters. So technically, the left upper trap is 1 centimeter tighter, longer than the right. So then the right is 1 centimeter tighter than the left. So that is upper traps, biceps, triceps. Then we could also do like a muscle length test of the external rotators and internal rotators. So if I want to have you scooch over to the left here. So I want to be extensive here. So this is similar to the passive range of motion, classical, but for internal and external rotation. So again, for this, if I'm testing the muscle length of the external rotators, I am going to be performing internal rotation as it puts the external rotators on its lengthening external rotators. And I would measure just like I did with the passive range of motion, classical there. And then if I wanted to stretch the internal rotators, which is the subscapularis, pectoralis major, latissimus dorsi, you can go into external rotation, and that will stretch that musculature. Then you can also test the pec minor MLT by just measuring with a tape measure the distance from the acromion to the table on the right side. So on the right side it is 6 centimeters. On the left side it is 7 centimeters. So pec minor is tighter on the left than on the right by 1 centimeter. So that's it for MLT. If you could please read to me the findings for muscle weight test.
Unable to test on the right due to muscle guarding and apprehension.
Unable to test due to muscle guarding.
It says see structural inspection for pec minor. The structural inspection says holds arm guarded against body, rounded shoulder bilaterally, pec minor length 8 centimeters from table to acromion bilaterally.
Hold on, I'm just trying to write all this down here. So it said see structural inspection and what?
After it said you can't do anything on the right, it says see structural inspection for pec minor.
Okay, and the pec minor says?
Pec minor length 8 centimeters from table to acromion bilaterally.
Bilaterally, okay. Is that it?
Mm-hmm.
Okay, so the patient is unable to perform an muscle length test due to pain and apprehension. I'm going to defer the manual muscle test at that point. So I'm going to go for the special test. So for the special test, there are quite a few special tests that I'm going to perform on this patient. I'm going to ask you to be standing, please. Okay, so for special test, so for NIRS, this is passive here, so I'm going to be testing your left, and then I'm going to test your right. So for NIRS, it's going to be internal rotation, and I'm going to just passively bring you up and out like this. Okay, so I want you to stay, I don't want you to rotate with your thoracic spine. Okay, so go up and out like that. Of course, the ceiling's preventing us from getting any higher, but that's how we would perform it. That's good. It did not help.
Took it long ways.
No. I just tried that. I just looked at the ceiling, basically. So, anyways, actually, I did this.
Okay.
Maybe. So then I'm going to do the Hawkins Kennedy. So this is where bring that shoulder up to 90 degrees, and then I perform this. It's for subacromial impingement and supraspinatus as well. So I'll do that. Perform bilaterally again, NIRS impingement test. So passively, rotation. Out. That. And then Hawkins Kennedy. Again. Just kind of uncomfortable too, just doing this even to help healthy shoulder. So that's Hawkins Kennedy and NIRS impingement. An empty can. So full can is thumb up, slowly out. So hold that up for me. Apply a little over pressure, and then I'm going to go into internal rotation right here, and then hold that over pressure. So that's empty can. Then sulcus sign. So for this one, I'm kind of stabilizing here. I'm going to be looking for the humeral head in relation to the acromion. So I'm going to be pulling inferiorly on the shoulder and seeing if there's increase in depression from like an increased gap of the humeral head from the acromion and on the affected side compared to the unaffected side. Some people are lax, so it's important to compare bilaterally. Apprehension test. Okay, so for the apprehension test, I need you to be on your back, please. Okay, so for the apprehension test, this is where I'm moving the shoulder anteriorly or posteriorly with kind of a glide, and then it's determining if the patient is having any apprehension or instability with this. So I'm going to be standing right here. I'm just going to grab the humerus. I'm going to move it posteriorly and anteriorly. And this is to determine if the patient feels any apprehension, instability, unsteadiness, discomfort, and if there's any increase in translation or increase in apprehension compared to the opposite side. So I did the right side first, but I'd perform the left side first. So again, performing posteriorly, anteriorly. So again, stabilizing the clavicle and the scapula, and then manipulating the humeral head anteriorly and posteriorly. Let's do it posteriorly first, and then anteriorly after that. Do that a few times. So next is the moving valgus. I'm doing that for that's for elbow, Tenels. Do that upper limb tension test. Median radian owner. Don't need to do that. Load and shift. So this is where I provide an axial load into the glenoid, and then I'm just kind of moving into multiple movements inside the glenoid. So again, loading, internally rotating, externally rotating, loading, going into adduction, abduction, horizontal adduction, and backwards as well into extension. That's the load and shift. Drop arm. So if you could stand up, please. So a drop arm is when patient has their arm up, so I'm going to do it on the right side first. So I'm going to have the arm up like this, and I'm going to ask them to hold it once I drop it. So I drop it, it stays up. Or another way you can do it is if I hold it and ask them to slowly lower it down, so slowly lower it down that way. This is for supraspinatus pathology. So if it's a positive test, if I drop the arm, it just falls forward, or a lack of control. Or if I ask them to slowly lower it down, it lowers down much faster than on the unaffected side. So again, over here, drop arm, just gonna drop it high and hold it up, and then slowly lower it down. That's the drop arm. Then the Adson and Roos. So what I'm going to do for this one is I'm going to have you let's do the unaffected side first. Keep this habit here. So I'm going to have you bring your right hand up. I'm going to have you extend your neck and then rotate to the right. I'm going to feel your pulse. I'm going to wait 60 seconds and see if the pulse is diminished on the affected side compared to the unaffected side. So say I completed on the left side and move on to the right. So now I'm going to do the Roos. So the Roos is where they have both their arms up like this, and you do this. You kind of go like kind of like the chicken dance, like this, for 3 minutes, and then you determine if they have reproduction of symptoms with neurological symptoms. So the Adsons and the Roos are special tests for thoracic outlet syndrome. So you test for pulse and you test for neurological symptoms after 60 seconds with those tests. So symptoms could be both either or both of neurological numbness, tingling, and numbness, and or lack of pulse. So with the Adsons, you are extending and rotating to the opposite side to kind of cut off or pinch the artery. Yergeson's. So this is for Yergeson's standing up. So what you want to do is kind of have you be like this. I'm gonna have you kind of flex the elbow and go into kind of opening of the wrist. Okay. So what I'm gonna do for this one is I'm gonna provide some resistance. Okay. So if you can do that for me, good. So I'll be palpating the transverse humeral ligament for this. So this would this is a special test for transverse humeral ligament tear, where the long head of the biceps possibly can tear or pop out, can tear the transverse humeral ligament or pop out of the glenoid glenohumeral groove. Or it's also a special test for slap tears. So the superior labrum, anterior, posterior is torn on the labrum. On here on this list, there is no bicep load, and I want to add that. So the bicep load, this is the last one I'm going to perform on you. I want you on your back, please. So the bicep load 2 test is for slap lesions. So for this, I'm gonna have you, again, I've come on the unaffected side, then I've come on the affected side. This is the affected side first. Just for camera reasons, I'm gonna have you open up your arm like this, and then have you come into external rotation, abduction 90 degrees, elbow flexion 90 degrees, and supination. I'm gonna have you pull into my hand here. Okay, so pull. So this is pulling on the long-handed biceps as it inserts into the superior labrum. If it was weak and or painful compared to the opposite side, or on the affected side compared to the unaffected side, that would be a positive test for a slap lesion as the bicep load 2 test. That was a lot, and I am eager to find the findings. Okay,
Positive
so
apprehension.
special test. Let me check that. Okay, positive apprehension. Anticipated that.
Positive compression rotation labral test.
Positive. That's compression rotation. Label test, okay. So that was the load and shift. Okay, sounds good. Is there anything else?
Positive sulcus sign.
Positive sulcus sign. Okay.
Negative empty can.
Negative empty can. Okay.
Negative impingement.
Negative impingement. Anything else?
Mm-mm.
Okay. All right. You're done. So the final pathology is a labral tear. So for apprehension, pain and apprehension, that's because the humeral head is gliding anteriorly or posteriorly on the glenoid, and it's excess range of motion and just apprehension from the or excess translation and apprehension from the humeral head into the glenoid. So that's usually indicative of a slap lesion, or of a, well, it could be a slap lesion of a labral tear, because the suction mechanism of the labrum is no longer as effective, which often occurs with a Hill-Sachs lesion. So a Hill-Sachs lesion, the shoulder goes anterior, posterior, translates on the glenoid, and it can tear the labrum as it does so. So as it translates. So for this situation, the labrum is torn. I'm intrigued to see if the bicep load 2 test would be positive, and which indicates a slap lesion tear, but there's nothing regarding that. But the compression rotation is a general labrum tear. So at least the labrum. That's the word I'm looking for. Just labral pathology. So I'm going to go with labral tear as a pathology. That's due to the special test. It's also due to the apprehension with anything with internal and external rotation, extension where the humerus has to glide anteriorly or posteriorly for passive range of motion classical, and for passive range of motion accessory, and for active range of motion. So anything that requires the humeral head to move anteriorly or posteriorly on the glenoid either cause pain, apprehension, or excess range of motion. Excess quantity, I guess I should say. It's hypermobile, 5 out of 6, which is quite mobile. As 3 is normal, 4 is hypermobile, 5 is super hypermobile, and 6 is just super lax. So, laxity and feel, displaced meniscus, labral a labrum and feel totally. So definitely a labrum at this point. My stage of condition is, I would say it's chronic at this point, or settled, considering that it happened a month ago and it stayed the same. The Hall-Sachs lesion is healed, which means that the bone is healed, but it looks like the labrum has not. So at this point, I would probably refer the patient back to the doctor and contact the doctor with my findings. And if the doctor wants me to continue treatment, I'd be happy to do that. So more conservative, physical therapy treatment, we would, since there is, see, was there any swelling or warmth? I don't believe getting that. But TFC, with the normal, there's no swelling or warmth. So with that, I can kind of go straight into strengthening around the shoulder. So with labral tear, the stability is compromised. So, and the labrum is compromised. The labrum is what helps kind of provide stability to the shoulder. So, and if it was in the sling for a while, up until just 3 days ago, it was immobile in the glenohumeral muscles of the rotator cuff, and even others like the pec minor and pec major, and I should say just pec major and latissimus dorsi, as well as the rotator cuff would be weak due to lack of mobility. So I'd want to strengthen all of those muscles. So I would do, TheraBands going into external rotation, TheraBands going to internal rotation. I would work on weights going into abduction this way and or this way to strengthen the supraspinatus, and then external rotation to help to work to strengthen this infraspinatus, supraspinatus, and teres minor. Want to do internal rotation with the subscapularis, teres major, pec major, latissimus dorsi. I want to maybe work on some perturbations, maybe so where I'm holding it up, like neuroread almost, or I'm holding it up, just kind of providing perturbations anteriorly, posterior, and just asking the patient to kind of hold the shoulder in place. I can also do that kind of for internal and external rotation as well. I can also work on some neuroread, kind of catching and throwing, so like a weighted ball, nothing too heavy, maybe pounder. You just need like a 1 or 2 pound ball. We're just kind of throwing it, catching it, and being kind of, the patient would appreciate that as well, because that's kind of working towards football, and you want to get towards more like, using the SAID principle, more specific football exercises as we progress with the plan of care. So if the surgeon or doctor doesn't feel like surgery is the way to go, we can, again, progress even further with PT, where try to get them back on the field by doing different football exercises later on, and really strengthen the rotator cuff, and even the more distal muscles, biceps, triceps, forearm musculature, flexors, and extensors. Tissue activity, missed that. So got stage of condition is chronic or settled. Tissue activity is high, considering I can't even get to an end feel, and I can't even perform that muscle length test. So, laxity, end feel. So that's high. So there's pain and apprehension before I even get to an end feel. Yeah, capsule laxity, end feel. Technically an end feel, but not really an end feel. And then for MLT, I'm not even able to perform it to even obtain an end feel. So medium to high, depending on how you want to describe it. Then subject reactivity is high, considering the patient is a student and low for being a student, I should say. Subject reactivity is low for being a student, because they're not having any issues with that, but high for working out, being a football coach, and playing football as well, is high, since they cannot perform those tasks. It'd be moderate if they could perform those tasks, but they're having pain, but they are unable to perform those tasks with pain. Unable to perform the task and pain. So that is subject reactivity, tissue activity. Goal for physical therapy at the end of the first day is kind of provide patient education kind of get buy-in with the patient. Since they're a younger athlete, you kind of want them to have a good relationship with the therapist. I'm also going to want to kind of teach, stay within pain-free range of motion, and stick within a pain-free range of motion. Maybe work on some strengthening exercises that are pretty light, because I want them to come back to me for the second time. So I know I'm just flared them up a bit doing all these tests, but I'm going to want to calm that down a bit and kind of keep them happy. So maybe do some ice to kind of prevent any swelling or anything like that. Maybe do some ESIM even just for pain management, since the pain's pretty high. 7 at its worst when it happened. Current is 4, best is 3 or 4 as well. So that's not good. I want to address pain. So that is what I have to say. Thanks for sitting through this long eval.